guys before we go ahead and begin. I know cardiac is quite difficult, so we're going to work through it. You guys all have access to my EKG video that I made for you guys, so we're not going to be spending too much time going over EKGs. We're going to do some EKG practice questions, okay? So let's begin. I gave you guys a couple tips for success, really, especially with our cardiac portion. Now we're kind of tiptoeing into that airway, breathing, circulation side of nursing, where we start learning to prioritize and all that fun stuff. So always assess your patient first. And when we're talking about assessing and delegating and prioritizing stuff, we're really going to use that airway, breathing, circulation, and the level of consciousness. Okay, one of the first signs and symptoms that your patient is not adequately perfusing well is going to be that altered mental status. So just kind of keep that in mind. Again, I'm not perfect. If you guys notice anything is odd, just please let me know. This is also not comprehensive. It's just an overview that's really going to help aid your studying efforts. Also take notes. I know these slides are quite lengthy, but I actually added in blank nursing in a nutshell slides for you guys to actually take notes on. That way, while you're doing, while you're reviewing, your copies of the slides, you actually have an opportunity to write down notes. So that's why I added those there. They are strictly for you guys to aid in note taking. All right. So first up, we just have a tiny portion of endocrine we are going to cover. So really, we're going to be talking about diabetes. Okay, so there's a couple things we need to look into when we're talking about diabetes. Number one, is it type 1 or type 2? When someone has type 1 diabetes, they do not produce any insulin. If you remember back to patho, insulin is our lock and key that helps us really absorb blood sugar. Okay, with type 2 diabetes, my body produces insulin. It just doesn't produce enough insulin, or my body is simply not sensitive to the effects of insulin, meaning insulin just doesn't do anything to my body. Okay, and that's usually due to lifestyle changes such as obesity, sedentary lifestyle, things like that, lack of exercise. For type 1 diabetes, this is an autoimmune issue. Okay, so review your normal blood sugar levels and what signs and symptoms might someone exhibit if they have hypoglycemia versus hyperglycemia. Well, hypo, this is our low blood sugar, so they are cool, clammy, and they need some candy. And then when we have our hyperglycemia, that is our hot, dry sugar high for these patients. And we're talking about HbA1c. This really measures our average blood sugar levels over the past 3 months. Okay, why do we want an A1C? Well, we get an A1C because if I ate maybe like 2 or 3 candy bars because I was having a very stressful day and my blood sugar was probably like 250, 275, does that make me diabetic? No, it doesn't. So the important thing with HbA1c is that it helps us give a bigger picture. It is an average blood sugar level over the past 3 months. So if my average blood sugar level was maybe like 7, then I'm diabetic. But that one-time incidence of my sugar being high or low, that doesn't make me diabetic per se. Again, we reviewed a lot of the differences between the two. So really focus on what some of these symptoms might be for these patients. With type 1 diabetes, we treat with insulin, and usually with type 2 diabetes, we treat with lifestyle changes. In the event those lifestyle changes do not work, we can give them metformin, which is an oral anti-diabetic drug. Does anyone know what our big concern with metformin is? And this ties a lot into our cardiac portion. But what do I need to know if my patient is on metformin? Why is it important I know if they're on metformin? I guarantee you NCLEX loves to test on this. What is a nursing consideration for metformin? It involves cardiac caths. Does that help? What must we do with a patient who is on metformin? Awesome job. Thank you, Sienna. We have to hold our metformin 48 hours before and after contrast dye. Why do we do this? Metformin is very harsh on the kidneys. Contrast dye, iodine, is very, very harsh on the kidneys. So if we give them both simultaneously, we're going to put our patient into acute renal failure, and that's not good. So you always have to hold metformin before we do any procedure involving contrast dye. For our purposes, we talk a lot about cardiac caths. Okay, so just really what I want you guys to review is your insulin types. I have a handout that I created for you guys, which I'll send. It's just a nice little handout on the different types of insulin, and just really be cognizant of when each type of insulin peaks. Typically, our intermediate acting peaks around 6 hours-ish, and it extends a little bit longer. So we need to know when the insulin peaks, because that is the greatest risk of a hypoglycemic event, meaning my patient's blood sugar might drop. Okay. And then again, review your sick day education material. Specifically, these patients need to continue to eat, continue to drink lots of water, and more frequently check their blood sugar when they are sick. They should not be skipping any doses. So now we're going to talk about cardiac. So I took your guys' considerations of pharm. And some said, we're having this issue where we haven't learned about drugs, in pharm yet. So I made a little cardiac review for you guys to go at your own pace. Specifically, this is you'll hear me refer to it as a cardiac cocktail. These are drugs that really don't have a specific reason that we give them. If there's any cardiac issue, we give them these meds because they all kind of do the same thing to kind of help reduce the workload of the heart. Calcium channel blockers, these are very nice drugs, verapamil, nifedipine, and diltiazem. We also have our ACEs and our ARBs. Our ACEs are our prils, and they're very, very similar to ARBs, except our ARBs are just more tolerated. Where usually if a patient has a really bad cough when they're on an ACE inhibitor, we're usually going to go ahead and put them on an ARB. We have different types of nitrates and cardiac glycosides. Nitrates, specifically our nitroglycerin. So review how to teach your patient how to use their nitroglycerin, meaning you take one tab, you put it under the tongue, wait 5 minutes. If you still have chest pain, give another one, wait 5 minutes. If you still have chest pain, another one, 5 minutes. And then if you still have chest pain after the third nitro, we need to call 911, okay? So, cardiac glycosides, digoxin, this is a drug of choice for heart failure. Just keep in mind, digoxin has a very narrow therapeutic window of about 2. So if we have dig toxicity and we have elevated levels of digoxin in the blood, these patients will see some weird halos and might be hallucinating a little bit. Most common drugs are beta blockers. These help slow the beat of the heart. So if I have an elevated heart rate, we give beta blockers, and they really, really help. Are cardioselective, meaning they only act on the heart. Non-cardioselective, such as propranolol and nadolol, these drugs work on both the heart and the lungs. So if you have any lung issue, you're probably going to opt for a cardioselective beta blocker. I guarantee you heparin and warfarin are bound to show up on exams and boards. So it's very important to know the differences between heparin and warfarin. Heparin works right away, but it is a little bit of a risky drug, so we really need to be monitoring their APTT every 6 hours. Okay, so review your normal lab values, your therapeutic range, and when you need to hold the heparin. Another drug we can give in place of heparin is Lovenox. Lovenox is a brand name, but it's also called enoxaparin. This is a low molecular weight heparin, and it's just safer for the patients. Okay, that's usually the shot you give in the tummy. Warfarin, on the other hand, a good drug for the patients to go home on. However, it does take about 3 to 4 days to start working. So my patient's going to be put on heparin and warfarin at the same time, but we keep them on heparin till their warfarin becomes therapeutic at around 2 or 3 INR. And that usually takes about 3 days. Just remember that vitamin K is our antidote for warfarin. Therefore, if my patient's taking warfarin and they overdose on warfarin and their PT-INR is 7, I'm going to give them vitamin K. But that also means if my patient eats a diet high in vitamin K, they could negate the effects of their warfarin. Time to familiarize yourselves with some cardiovascular equations. It's important to know what these are and how to calculate them and what they mean. So when we're talking about our MAP, what I like to do the top equation. That's your S plus 2D over 3. That's just what I like to use, but there's another formula as well, which is your diastolic plus the difference between your systolic and diastolic over 3. I don't like the bottom one because that's more opportunity for error. Now I'm adding in subtracting, and while subtracting is pretty simple, you could theoretically have an error in that math. But do whatever you're most comfortable with. And really, it's important to know what our MAP is because this number tells me how well am I perfusing my organs. If I'm not perfusing my organs well and my MAP is at 50, I'm concerned that my organs, my brain, and all the above are going to be starved of oxygen. Pulse pressure, on the other hand, helps us really know, like, what is the force that my arterial walls have to, like, exert to get this blood out. If I have a very, very low pulse pressure, this means I might have a heart failure and I'm just having a hard time getting that squeeze to kind of send blood out. If I have a very high or widened pulse pressure, it means that, like, my heart is just, like, going crazy. But in this case, these patients usually it's a result of like coronary artery disease, which is just that constant stretching and atrophy of the heart muscle. And that's where you'll see a wide pulse pressure. And then finally, we're all familiar with blood pressure. Additionally, you should know how to calculate cardiac output. In the event you had a math question like this on an exam, you would be given 2 of the values, whether it be cardiac output, heart rate, or stroke volume, and you would have to figure out the missing value, okay? And this really lets us know how much blood is going through the ventricles. And finally, we have ejection fraction. And this is a really important concept when we're talking about heart failure, because heart failure manifests in 4 key different areas, technically 2 different areas that can be then split into 2 more classifications. And we'll talk about that. But just know that if I have a low ejection fraction, it means that I'm having a lower amount of blood exiting the aorta and going out to the body. And what can that contribute to? It can contribute to our what's the word I'm looking for? Kind of that altered mental status I talked about earlier, or organ damage, organ failure, things like that. So now we're going to go ahead and review hypertension. So again, similar to the analogy I made earlier, where just because my sugar was really high once, that doesn't make me a diabetic. Well, kind of the same thing with hypertension, which is why we look at our BNP. So what is BNP? Basically, it's just a hormone secreted by the heart that lets the body know, like, I'm being stretched. I'm being really, really stretched. So what causes this stretching? Constant hypertension. So elevated BNP gives us a better picture on what is really happening. Maybe they took my blood pressure and I was just really scared because I was in the hospital, and that's probably why it was up. But one of the main things you're going to need to know is our risk factors that kind of contribute to hypertension. So our major risk is going to be our diet, okay? So this is why we really need to pay attention to our patient's cholesterol panel, because cholesterol panel can contribute to hypertension. Specifically, be familiar with your normal lab values of total cholesterol, triglycerides, LDL, and HDL. Something I like to say is we want a high HDL because it's our happy cholesterol, It's our good cholesterol. We want a low LDL because that's our lousy cholesterol. Okay. Lots of different causes of hypertension. Specifically, our essential is going to be our most common, meaning we don't really know what the cause of the hypertension is. We can say that it's linked to obesity, sedentary lifestyle, increased triglycerides, family history, blah, blah, blah. But is that a definitive cause? Not really. So we classify it as essential hypertension. Now, if we had secondary hypertension, we have direct proof that there was a cause. A big example would be pregnancy-induced hypertension. We know that the pregnancy caused the hypertension. We can't say for certain that your hypertension was caused by your diet or by your lack of exercise. It's kind of a combination of a bunch of different things, if that makes sense. But again, review the differences between modifiable and non-modifiable risk factors. If it's a modifiable risk factors, you have an opportunity for patient teaching. Okay. Unfortunately, with hypertension, there's not a lot of signs and symptoms, which is why it's kind of known as that silent killer. And essentially, because of the hypertension, we'll have some decreased cardiac output, decreased ejection fraction, things like that, which over time starve the body's organs of essential oxygen. So, what do we do for hypertension? We use, again, our cardiac cocktail, our ABCD, your ACEs, your ARBs, your beta blockers, calcium channel blockers, and diuretics. General cardiac med kind of warning, always check your heart rate and blood pressure before you give them some cardiac medications, because the whole job of these meds are to lower heart rate, lower blood pressure, which is a-okay. But what happens if my patient's blood pressure is like 80/40? Do I want to give them like an ACE inhibitor? I don't. Why? I'm going to bottom them out, and that's really not good. So always assess your patient first. Another thing that we are going to teach these patients to do is to maintain a healthy BMI, get in some exercise, and follow the DASH diet. That's just your dietary approaches to stop hypertension. So be familiar with some foods that have low sodium content. Good rule of thumb, if it's from the pantry, it's probably got a lot of salt in it. So maybe instead of some like eggs and bacon and sausage, a good breakfast choice for these patients would maybe be some oatmeal and some fruit, okay? Or some yogurt and some fruit. So just be familiar with that. Because again, you wouldn't think it, but the job of the nurse is when you're in clinical, if you're kind of there during lunch and dinner time, you help your patients order the food. And if they order something that's not within their diet, you'll get a call from the food service and they'll say, hey, they ordered this, but that's not part of their cardiac diet. And you'll have to be the ones that kind of sits down with your patient and says, hi, I know you really want this, but this is going to be a better option for you. So that actually is a job of the nurse, okay? We talk about coronary artery disease. We're having plaque buildup. Really? Well, if it's coronary artery disease, you have plaque buildup in the coronary artery itself. But it stems from atherosclerosis. What is atherosclerosis? This is just the fatty buildup of lipid plaques in any of our arteries. We have femoral arteries, we have radial arteries, we have carotid arteries, we have a lot more arteries in the body. But when we're really talking about CAD, we have this atherosclerosis of the coronary arteries. Now, why are the coronary arteries important? They supply blood and oxygen to the heart. If you ever hear me talking like about blood a lot, what is a major component of blood? It's our hemoglobin. That's our oxygen carrying capacity. So wherever blood goes, oxygen will go with it. So even if you don't hear me saying like, oh, delivering oxygen, we know that blood carries oxygen. And that's really the purpose of blood. Blood is great. Blood is awesome. But why is it so great? It's because that oxygen it carries. Okay. So when we're talking about chronic stable angina, this is when I have those plaque buildups in my coronary arteries, but I'm stable right now, meaning on the normal day-to-day, I'm able to supply my heart with enough oxygen. But if my heart is under increased stress, like if I go running or if I had a traumatic event happen and the increased oxygen demand in my heart goes up, well, because my coronary arteries are still pretty closed, they're no longer able to keep up with the new demands of my heart. So how do we know it's chronic stable angina? Angina is just a fancy word for chest pain. How do we know it's chronic and stable? Well, it's relieved by rest and nitroglycerin. Okay. So just kind of review some of your risk factors, signs and symptoms, etc. Okay. If you ever suspect something cardiac is going on with your patient, here are some labs you can get on them. You can kind of get some troponins done. Troponins basically just tell us if there's damage to the heart. Okay, so if you have elevated troponins, meaning there's a lot of damage happening in the heart. Well, what causes damage to the heart? Inadequate oxygen. Okay, so if you have a troponin level of 600, your patient's probably experiencing a myocardial infarction. Okay, we can also do some stress tests and cardiac caths. Again, lots of different things we can do, but if I do have lots of plaque buildup of my coronary arteries, I can undergo cardiac cath. Cardiac catheterization is when we inject the contrast dye, usually into your femoral or your radial artery in your hand, and it really just lets us know how much blockage is there, if you will. So essentially, what do we have to do to prep our patient for a cardiac cath? Well, we need to make sure consent is signed, and we have to ask our patient, do you have any allergies to some iodine or some shellfish? If they do, they might not, you're going to have to talk to the provider. They might need a different form of dye because they could have a really, really bad allergic reaction, or they might bolus them with like some steroids or something like that before. What do? We hold our metformin for 48 hours. Post-op, we really want to make sure we're doing full assessments, and we're really looking for hematomas or bruising on the back, especially if they went in through the femorals. We need to know if there's internal bleeding happening, okay? Always check the pulses distal to the insertion site, and if it's bleeding, you need to hold pressure, and you just keep holding pressure. So, what do? We keep the extremity straight for 6 hours, okay? They cannot move it, they cannot bend it, it has to keep straight, okay? Myocardial infarction, this is also known as our unstable angina. So we talked a lot about stable angina. Well, now what happens when it becomes unstable? So essentially now my heart is not able to keep up with the oxygen demand on the day-to-day. Now, without adequate oxygen, we will have ischemia. But ischemia is not right away. Essentially, if you get a like a STEMI alert or an MI alert, and the patient comes into the ER, they have a 1 hour door to intervention window, meaning by the time they enter the ER, I need to get them under for a cardiac cath within an hour because I need to open up those coronary arteries. If I don't, there can be irreversible damage, often preceded by our CAD. Cardiomyopathy is something a little bit different. Cardiomyopathy, this is usually what precedes heart failure. So essentially, over time, my heart's had to work extra hard, whether it be from hypertension, CAD, all the above. My heart's had to work extra hard. Well, what happens when it works hard? It becomes thick, it becomes stiff, and it becomes tired. Cardiomyopathy will eventually lead to heart failure. So go ahead. It's not super important to know the differences between dilated, restrictive, and hypertrophic, but I did include those for you guys. Our gold standard for a patient who has cardiomyopathy, which when you think cardiomyopathy, I want you to think heart failure. So what is our gold standard? Well, we need to get an echocardiogram done on these patients. An echo tells us ejection fraction. That's all it does. It shows us a nice little picture of like the heart, like an ultrasound of the heart, but it really lets us know what ejection fraction is happening. Okay, and ejection fraction, again, it's important. How well are we perfusing the body? So again, we have our cardiac cocktail of different meds. And what we as nurses have to do, if we have a patient with a new diagnosis of cardiomyopathy or heart failure, we need to make sure that they've gotten an echo done because that's something a provider would want to know. What was your echo 2 years ago and what is your echo now? Are you getting better? Are you getting worse? They also need to be sent home on an ACE or an ARB. Again, I included this slide for you guys. This really is a good diagram of blood flow through the heart. Now, what I want you guys to understand is, I know people are like, don't memorize the chambers of the heart. Hear me out. if you have a massive brain fart during your exam and you just get anxious, if you can remember two things, you can figure out the answer. Number one, where did the blood come from? Number two, where is it going? So what do those pieces of information tell us? Well, if I have a traffic jam or a blockage, it's going to get pushed back to wherever it came from. Now, well, where's it going? Well, if it cannot go to where it needs to go, what are some implications of that, or what would be of concern? So with the right side of the heart, what the right side of the heart does, it takes blood from the body and it sends that blood out into the lungs to become oxygenated, etc. Left side of our heart, where does the blood come from? It comes from the lungs. Where does it go? Out to the body. So just kind of keep those concepts in mind. So really, we're going to hone in on heart failure right now. If I have a left-sided heart failure, it means that the left side of the heart is not doing an adequate pumping job. If it's not doing a good pumping job, it's going to cause a traffic jam. The blood is not going to be able to effectively go out, so it's going to get stuck in there and eventually pushed back. So what do some of these symptoms look like? Well, the left side of the heart received blood from the lungs, so therefore it's going to go back into the lungs. So how is that going to present? If I've just got all this fluid and blood backing up into my lungs, I'm going to have pulmonary symptoms. Same thing with the right side of my heart. If the right side of my heart cannot push it into the lungs, it's going to back up. Where's it going to back up? It's going to back up into the body because that's where it came from. Specifically with left-sided heart failure, we are concerned that it can progress to right-sided heart failure because as it continuously backs up into the lungs are then going to shove it into the right side of the heart, and now the right side of the heart has to work extra hard. When we talk about HREF versus HPEF, there's one key difference, and it is the ejection fraction. So this is also why it's important to know what's happening during systole and what's happening during diastole. So systole is our squeeze out to the body. So if we're having this nice big squeeze, that means we're perfusing. Therefore, if I have systolic heart failure, it means systole ain't happening very well. Therefore, you're going to have a reduced ejection fraction. If you have diastolic heart failure, what happens during diastole is just our filling phase. So is there any issue with sending it out to the body? Not really. Therefore, patients with diastolic heart failure will have a preserved ejection fraction. That's just all that this means. So again, I mapped this out for you guys, but again, now we're just adding the two. If you have left-sided heart failure that is systolic, you are going to have all these lung symptoms and you're going to have a reduced ejection fraction. Okay, so just kind of, if you can understand the basics of it, you can kind of figure it out. Again, same medication considerations. Okay, one thing to keep in mind when you have a patient in heart failure, you will be constantly doing daily weighs. Why? Remember, with our right-sided heart failure, fluid is being retained in the body. So they might need to be on some fluid restrictions, or you might need to be giving them some diuretics to help get fluid off. Okay, because all that excess fluid actually will contribute to an elevated BP. So we're going to talk about some of our valve disorders. Again, I just included this slide for you guys, just because I think it's a good picture slide. So when I start talking, you'll be able to really see what's going on. Okay. So when you hear that first S1, that is when systole starts. Okay, when systole ends and diastole begins, you hear S2. So if you hear something odd, that means that there's like an ectopic beat happening. Okay. So again, I mapped out this picture of valves like I talked about earlier. If you can figure out where it came from, you can figure out where it's going. You can kind of walk yourself through some of these practice problems. Or when you're taking your exam, you can also walk through it. So when we're talking about stenosis, my valve is thick and stiff, meaning it's having a hard time opening. If I'm having regurgitation, it means my valve is just really pulled apart, puckered, and it's not going to close. So what happens if it can't close? Well, there's going to be some backflow. Okay. You ever drink water and it went down the wrong pipe because something didn't close right? Same concept. So when we're talking about aortic valve stenosis, well, what does the aorta do? Or what's the function of the aorta? It helps send blood out to the body. So if my aorta is not opening, I'm having a really, really hard time sending blood out to the body. That's why you might hear a systolic murmur. Okay, and where you're going to auscultate, well, for aortic valve stenosis, you're going to auscultate the aorta. So just kind of highlight, review, star what you might hear and where you would hear it. And unfortunately, those are just things you memorize. Aortic valve regurg. This means that after blood has been sent out to the after it's gone through the aorta to go out to the body, some of it can actually splash back in, and that's not good either, okay? Because all the blood's not going to go out to the body. So what will we hear? We'll actually hear a diastolic murmur for this, because what's kind of happening after blood has been sent out to the body? Well, diastole begins. So I'm going to start hearing these excess sounds during diastole, because that's the valves kind of opening and, whatever, the blood kind of going back in. So that's why we actually hear a diastolic murmur for aortic valve regurgitation. Okay. What are we going to do? We auscultate at Erb's point. Talking about mitral valve stenosis, we really are going to have an issue with our mitral valve, which is kind of in the middle of the left side of the heart. What can we do for mitral valve stenosis, or really any valve issue? We can actually do some valve replacements. There's two options for a valve replacement. You have your biological and you have your mechanical valve. So what are some benefits of both? Just go ahead and review that. Typically, our biological valves do not last as long as mechanical, but they are a little bit safer in the fact that they are less thrombogenic, meaning less prone to clots. Meanwhile, mechanical valves will last a long time, but they're pretty thrombogenic. So your patient's going to need to be on constant antiplatelets, okay, aspirin, just to kind of help make the platelets less sticky, less likely to clot. So we will kind of hear a bunch of different sounds with mitral valve stenosis as well. Mitral valve regurg, again, same concept. There's an issue with backflow. And we're talking about surgical treatment. We can actually opt for an annuloplasty to help kind of tighten and help that ring stay closed, okay? So what are we going to auscultate for mitral valve regurgitation? We're really going to auscultate the PMI for a radiating high-pitched holosystolic murmur, okay? Our mitrals are a little bit different because the mitral valves are like in the middle of the left side of the heart. When we're talking about anything aortic, well, what happens at the physical site of the aorta? It sends blood out to the body. So now we're going to talk about our electrical activity of the heart. So when we talk about defibrillation, this is done on a patient who is dead. Know where to put the proper AED pads. And what in the world does an AED do? Well, the AED has to see a rhythm that's like obviously not like a pulse rhythm, but an AED identifies electrical activity in the heart. Once it identifies the electrical activity in the heart, it shocks all that electricity out so that the heart can kind of be very less stimulated. And so the heart can say, okay, all this crazy electrical activity has subsided. Let me take a deep breath in, a deep breath out, and let me see if I can restart on my own. Typically, this is why your patients who are a little bit younger do well after maybe one defibrillation, whereas your older population might not even make it, but they might require multiple shocks, because what does a shock do? It just removes electrical activity from the heart, so the heart can take a deep breath in and a deep breath out and restart itself. What is cardioversion? Cardioversion is done on a patient who is not dead. So when you think cardioversion, just kind of think resyncing. It's not necessarily removing electrical activity. It's just like resyncing the heart. It's not restarting the heart. So this is usually done for patients who have like dysrhythmias that just are pretty symptomatic. such as Afib with rapid ventricular rate. These patients might be frequently short of breath, dizzy, have a headache. They might elect to undergo cardioversion. And this just helps us, you know, take a non-lethal rhythm and just make it a bit more manageable. ICDs, on the other hand, trigger the heart to contract. So if my heart's having a difficult time contracting, whether it be contracting in the atria or the ventricles, the ICD is going to trigger my heart to do that. So really review your troubleshooting for your ICDs. Review failure to sense, failure to capture, and failure to pace. Because if you have a patient that's having any issue with their ICD, that's really the only thing keeping their heart beating at a normal rhythm to keep them alive. So that's something we need to communicate to the provider ASAP. So now I have an interactive portion for you guys. So please, please, please pop up in the chat what you think is happening. Or if you're brave, you can shout it out. So I have a couple EKGs for you guys and a few slides, and we're really going to go practice looking at them. So in a nutshell, we always need to figure out what we're doing first. Always figure out what makes normal sinus rhythm normal, because if you can identify the normals, it makes it a lot easier to identify the abnormal. Okay? Again, this is for your review. So, what do you guys think is happening with this rhythm? Yes, this rhythm is sinus tachycardia. When I did a review for in person with the Tampa group, I got a lot of, questions on this rhythm. So, is it a normal rhythm? Yes. How do I know it's normal? Well, they always teach you make sure that there's a P wave for every QRST. But sometimes you might have a little bit of a hard time finding the P or the T wave, especially if you have a patient who might be moving about a lot or whose heart might not be the healthiest. Something I always do, I look at my R to R interval, and this for me is what helped me the most with EKGs. So what if I look at my R to R interval, in between the first and the second and the third and the fourth, and so on and so forth, there's equal distance between each peak, each top of my QRS complex. That's my R. So that's how I know that this is normal. If this were to be a 6-second strip, well, I counted 12. Beats 120. Everything else is normal. It's just quick. So usually this is caused by our fight or flight happening. So what do we always do first? We always assess our patient. Maybe they're anxious. Maybe they just got up and walked. But assess them. Are they symptomatic? If they are symptomatic, we can give them some beta blockers as well. Why is it 12 and not 13? It might have been 13. Maybe I miscounted. Oh, so really see how like one of the QRSs is a little bit cut off. If it doesn't perfectly fit in the strip, we typically don't count it. But I don't think you'll have kind of an example that cuts off like that. But if you did see that, if it's, because see how it cut off before the T wave ended? Where the T wave ended? That's why it would be 12 and not 13. No problem. We gotta have full stuff happening. All right, what do we think about this one? Awesome. So this rhythm is A flutter. How do we know that it's A flutter and not A fib? Well, for A flutter, we have sawtooth P waves. So we can clearly see the P waves. They're just weird and sawtooth, and sometimes I have a couple P waves happening. Whereas if when we have atrial fibrillation, we might not even see a P wave, to be completely honest. But when you think A flutter, think your sawtooth P waves. Okay? Again, always assess your patient first. Typically, a flutter presents with an elevated heart rate. So assess them. What do you think people who have an elevated heart rate look like? Well, probably short of breath, probably dizzy, probably headache, etc. What do we think about this one? What do we think's happening here? Yep, this is artifact. So if I see this on the monitor, what am I gonna go do? Am I just gonna like keep charting and, you know, go on my merry little way? Yep, we're gonna go ahead, we're gonna check their leads, we're gonna knock on the door. Mr. Smith, are you okay? Just in case, okay? Usually what caused this, the patient's probably moving about the cabin or they're, you know, putting on some comfy clothes or something like that. All right, what do we think about this? I know this can be a little bit difficult to see, so I kind of circled it in teal. What do we think is happening right here? Yep, so this one is normal sinus rhythm, but it's not a PVC. Yes, this is a PAC, premature atrial contraction. How do I know that this is a PAC and not a PVC? Well, number one, PVCs look a lot different. They have a really wide, tall, bizarre, distorted Q wave, or sorry, QRST complex. How I know that this is a PAC is, well, what's happening with the atria? Well, look, I have PQRS, and then it seems as though I can't, is that a P wave or a T wave? I don't know, which means something came early. So we have a premature P wave hiding in the T wave. So my atria, because that's what really kickstarts the P wave, is that electrical depolarization through the atria. That's what happens during my P wave. So essentially my T wave is trying, you know, because what happens during the T wave, that's just depolarization. But before my T wave finishes doing its thing, my atria is like, come on, it's time to go. Let's kick this QRS complex off. Let's kick it and keep going. I actually got a few questions saying, well, why wouldn't this be like Afib if that's that weird premature like P wave or whatever? Well, notice how it was just one beat and then the rest of it was a normal sinus rhythm. That's how we know it's a PAC. So essentially, their heart just went a little fast, and they honestly feel like their heart skipped a beat. Why did they think their heart skipped a beat? Well, I was going bump, bump, ba-bump, bump, bump, ba-bump. So like I kind of like technically really did skip a beat because I never had full time to recover from that beat. So, my friends, what do we think this rhythm is? Any thoughts? What do we think's happening here? Do we think this is sinus bradycardia or do we think this is heart block? I got a lot of questions yesterday about that. Do we think it's sinus brady or it's first degree heart block? Awesome job. So this is sinus bradycardia. If it were heart block, the long space in between would be between the P wave and the QRST complex. But we have P, QRST, dot, 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 P, QRST, dot, 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 dot. So that's how we know that this is sinus brady. So what do? We assess our patient. I sound like a broken record. Assess your patient. If your patient's an athlete, this is probably normal for them. Lots of things could cause this, but just keep in mind if maybe your patient is a trauma patient and suspected head injury, maybe this is due to that increase in intracranial pressure. What are some treatments we can do? Well, we can kind of go and we can do pacing with the cardioversion. They could actually get a pacemaker implanted for chronic symptomatic bradycardia, or if it's just kind of like an acute situation, we can give atropine. All right, friends, what do we think this one is? Yep, this one is first degree heart block. So something I always look for, I look at kind of my R to R interval, seems pretty normal to me. But then when I go and I actually look at my rhythm, I see P dot 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 QRST, meaning my atria depolarized, but now my ventricles are just taking a little bit longer. So there's an issue with electrical activity with the knee ventricles. So for this, really not much is done for first degree heart block. It can actually be just pretty common in some patients, and they might just have a history of it. So really monitor them for symptoms. If they become symptomatic, then we might opt for some cardioversion. What do we think about this one? Awesome job, guys. This one is Afib. I'm not gonna lie to you, I precept on a cardiac floor, and there's been many a times my preceptors ask me, Tiff, what rhythm are they in? And I look at something like this, and I say I have no idea. This is Afib. So from my advice, Afib almost every time will present with an abnormal R to R interval. So see how we have kind of a medium space in between the 1 and the 2, then tiny, then big, then medium, medium, big. Just see how my R to R interval is just wonky. It's different every time. That's pretty characteristic of Afib. And then when I go and look at the rhythm, I'm having a hard time seeing like my P wave, to be honest. So for me, even though I know they always teach you go PQRST, PQRST, the first thing I honestly look for, and this is just from working on cardiac floor, I always look at my R interval first, and I find that I have a bit more success with that. So what is our major concern with Afib? What am I really, really, really concerned about? I'm concerned about loss of cardiac output. What specifically am I concerned about with atrial fibrillation as opposed to any other like electric funky thing happening? This is a really, really big one. So with AFib, our number one concern is clots, okay? Let's pretend. This is my atria, and these are my ventricles, okay? Ventricles are at the bottom. If my atria is not squeezing as effectively because it's lost that atrial kick and it's giving out like some weak random squeezes, it means that all the blood from the top is not draining to my ventricles. So what happens when it's not draining to my ventricles? I don't know if you guys can even see it, but if it stays up there and doesn't get down here, it's going to clot, okay? If it stays in the atria because my atria isn't squeezing all of it out, it's going to clot in the atria. What do we know like anatomically about the atria? Well, there's little pockets in the atria that blood specifically likes to pool and clot. Well, what happens if those clots come out of the atria and go into venous circulation? It's not good. DVT, stroke, all the above. So with Afib, if your patient has a history of Afib, we're going to put them on some antiplatelets, put them on warfarin, all of it. So what do we think this fun friend is? Yes, there are PVCs. How would we classify this though? The PVC, but what would I say? If I saw this on the monitor and I was gonna do an S-bar with my provider, what would my assessment be? What would I say this is? So it's not a couplet. I see where you're coming from, but it's actually bigeminy. Although there's 3, when are they occurring? They're occurring every other beat. If it were a couplet, I would have regular beat, PVC, PVC, PVC. But it's happening, I have a normal beat, PVC, normal beat, PVC, normal beat, PVC. Therefore, every other beat is a PVC. I would classify that as bigeminy. So this is normal sinus rhythm with bigeminy PVCs, meaning every other beat is a PVC. If I had normal beat, PVC, normal beat, PVC, that would be trigeminy. Every third beat is a PVC. What's interesting, when counting the underlying rate, would you include the PVCs? This is where it gets interesting. No, I'm not. However, if my patient was on continuous monitoring, the monitor would technically count this as 60, okay? Because the EKG reads any electrical activity, regardless of if it's a perfusing beat or not. But if I, as a nurse, was taking a pulse rate on this patient, I would only feel 3 beats. So for us as nurses, we do not include this in the heart rate. Technically, this patient's heart rate's 30. Okay. I had a patient that had bigeminy PVCs I was taking care of, and on the monitor showed a heart rate of 87 or 89, and then when I felt both radial pulses for a full minute, I only counted 42. It makes sense. Every other beat was a non-perfusing beat. That's why I didn't feel anything. That's why we do not calculate that when we're talking about heart rate. So yep, this is a PVC. Great job, guys. So now we're going to talk about some of our systemic cardiac disease. So first up is peripheral vascular disease. There's 3 different types of peripheral vascular disease. We have our VTEs, our varicose veins, and venous insufficiency. So what's happening with peripheral vascular disease? Essentially, blood is pooling in the lower extremities. It has a hard time getting up. So what will these patients present with? Okay, sorry, I will go back. I just saw your question pop up. Let's go back. So can you repeat bigeminy versus trigeminy versus couplet? So couplet, think 2. I have 2 back-to-back PVCs. So if I had a normal beat, PVC, PVC, that would be a couplet. If I had normal beat, PVC, 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 normal beat, normal beat, normal beat, normal beat, that is a couplet, okay? When we have bigeminy and trigeminy, that's now every other beat. So the bigeminy and trigeminy tell us how often a PVC is occurring. When we're talking about couplets or quartets, that's how many PVCs are happening back to back. Why are we concerned with back-to-back PVCs? Well, once someone starts having 5 PVCs in a row, they can have a run of VTAC. VTAC can put them in a lethal rhythm. So it's important that we assess, like, is it a couplet? Is it a quartet? What's happening? Because I want to know if my patient's going to have a run of VTAC, a lethal rhythm. But I also need to know, like, bigeminy, trigeminy, because if every other beat is a non-perfusing beat, I'm going to have some pretty poor cardiac output. Does that help? I also go a little bit more in detail in my cardiac rhythm lecture. No problem. All right, back to peripheral vascular disease. We'll just start back from the top. So 3 major types. Just think that there's an issue with blood returning to the heart. It is pooling in the extremities, so my patient can have VTEs, varicose veins, and some venous insufficiency. Why are they at risk for VTE? Well, when blood pools anywhere, it likes to clot. So lots of risk factors, specifically our Virchow's triad for a VTE. So what do these patients look like? They're going to have big, swollen, like edematous, warm lower extremities because all that blood is pooling in their feet, essentially. They'll also have an elevated D dimer if they have clots, because D dimer lets us know if there are clots in the body. Their ankle brachial index would actually be a little bit elevated past 11, because think about it, there's all that swelling happening in their legs. This slide is from pathophysiology, but it just kind of goes into how we classify if someone is at risk for VTE. If they have all 3, they're at really big risk, okay? Almost everyone has 2 in the hospital. Almost everyone has 1, because almost everyone in a hospital gets an IV or a shot or something, so that's damage. And then when you're in the bed, even though they like move a little bit, our patients in the hospital don't move nearly as much as they would on the day-to-day basis. So just kind of keep that in mind. We really want to monitor all these big swelling, engorgement, and all that stuff, but also prevent a pulmonary embolism. If they do have a VTE, we're going to give some heparin for these patients, okay? If they do have a DVT, we can use compression socks, but we're not going to want to massage the area. What do we do? We're going to monitor them for the drugs that they're on. So again, really go back to those farm slides and review APTT, INR, all of those stuff. And what can they do to help with the pain? Well, have them elevate their legs. If all that blood is pooling in their extremities, have them elevate it so the blood kind of goes back down and just take some pressure off of them. Now, when we have peripheral artery disease, think lots of atherosclerosis in the arteries, meaning it can't get to where it needs to go. I mean, it does, but not at the rate it should. So I'm having a hard time getting blood down. And one of the most hallmark signs and symptoms of these patients is intermittent claudication, meaning they have a lot of pain when walking. So what do we tell them to do? Well, we tell them walk till you feel pain, take a deep breath, wait for it to subside a little, and then keep going. We want to keep going. This is going to help strengthen the tone of the arterial walls. Again, lots of different risk factors, so just review those. But usually these patients will have just pale, shiny, mottled skin, hair loss of the legs, because think of inadequate oxygenation to the legs. It's really what's going on. So what do we do? Well, lots of our antiplatelets, our peripheral vasodilators, our statins are really good at helping, lower cholesterol and kind of help blood get to where it needs to go a little bit easier. So what do we do for these patients? Well, if blood has a hard time getting down, have them keep their feet down. If we have them elevate their feet, now we've just kind of worsened the problem. So really helping them keeping their legs dangled is going to be really, really good. Okay, these patients, we don't want stockings or scads, because that's going to reduce blood flow to the lower extremities. So they're quite opposite. I also gave you guys this slide because I think this really, in a nutshell, puts it all together. Finally, we're going to talk about anemias. Really, for anemias, we want to know our normal values and kind of this chromic versus cytic. I encourage you, if you can figure out what the cause of the anemia is, we can figure out what the treatment's going to be. Okay, makes sense? So let's go. When we're talking about MCV or arthritic, this is how big the red blood cell is. So if it's big, is it small? What's going on? When we talk about the MHC, this is hemoglobin content. The more hemoglobin, the more red it's going to be. And if it's red, it's normal. If I have reduced hemoglobin, it's going to be hypochromic. Okay? Our MCV and our MHC are really what we're going to focus our energy on. Okay? Anemia nursing is pretty much the same for most of them, except when it comes to treatment, but a lot of them present with similar signs and symptoms, such as kind of like their red tongue, decreased O2 sat, shortness of breath, pallor, activity intolerance, etc. And a patient with anemia will need to have frequent follow-ups just to make sure that their hemoglobin is getting better. So, iron deficiency is the most common type of anemia. So just kind of keep that in mind. They're really all iron deficiency anemia is I just have low everything. I have a reduced number, I have a reduced size, I have a reduced hemoglobin content because I'm not getting enough iron. Iron helps us make new healthy oxygenated red blood cells. So that's why you're going to see microcytic and hypochromic anemia. Okay. When we're talking about treatment, if there's an underlying cause, such as blood loss, we're going to do some packed red blood cells. But if it's just dietary, we're just going to have them, either take some supplements or increase their red meats, review some of our different types of foods that are really high in iron. Also, if we're eating something like a burger or a steak, if you actually take it with orange juice and tomato juice, it helps increase the absorption of iron. But if your patient is taking oral ferrous tablets, oral iron tablets, just let them know it's probably going to turn their stools pretty dark. Aplastic anemia, on the other hand, we just have reduced number. So it's going to be normocytic and normochromic because nothing is wrong with the red blood cell itself. They're fine. I'm just not producing enough. Okay. So what are we going to do? We're going to give E alpha. What does E alpha do? It helps stimulate the production of red blood cells and hemoglobin. Therefore, if my patient is getting E alpha, I need to check their H&H, and I also need to check their blood pressure. The reason I check the H&H is I want to make sure that their hemoglobin and hematocrit are not too elevated, because if those numbers go beyond the normal lab values, now I'm concerned that the blood is just really viscous and it can clot. Pernicious anemia, this is caused by the inability to absorb B12. B12 really works kind of hand in hand with some of our ferrous and stuff to just help form new red blood cells. The funny thing with pernicious anemia is that it's not a dietary situation. It's just my body physically can't absorb it. So I can give them all the vitamin B12 that I want. If my body, if my intestines cannot absorb it, I can't use it. That's why these patients need injectable B12. So it goes straight into the bloodstream. Because when we eat stuff, it goes to the intestines, absorbed in the intestines, then it goes into the bloodstream. But my intestines aren't absorbing it. Therefore, I got to get an injection. Okay. And finally, our most unknown is our folate deficiency anemia. Folic acid works with vitamin B12 to help make new red blood cells. So really, what am I going to do with folate deficiency anemia? Increase my folic acid consumption. Okay, so I included some good dietary choices and whatnot for you guys. So just kind of review that. If you can understand what's causing the anemia, you can figure out what the treatment's going to be. And that's my best advice. Also just kind of reviewing, especially for the first two, really what the classifications were. So that is all I have for you guys. Thank you so much for joining. Does anyone have any questions?